Now, shifting to, I know a hot topic is people are wondering about different combinations and do you use three, do you use four? So you had talked to me about the move to quadruplets. In particular, we'll talk about the GMMGHD7 trial, which, oh my gosh, alphabet number soup. So it's a phase three clinical trial. You had 660 plus patients enrolled in this, but tell us high level, what really is the importance of this study?
Yeah, so when we look at the state of the union of myeloma right now, we've shown over the last decade that going from two drugs to three drugs was important and better for patients, that it gave them a deeper and more durable remission, typically before a transplant, and kept them in remission for longer. So now the next wave of question is, well, if three is good, is four better? So we're taking our typical three drug combinations, in this case, something called VRD, or the Velcade, Revlimid, and dexamethasone, and adding a fourth drug to it. And there are two studies that looked at this. The big one, the one you mentioned, the German myeloma group study, where we added isatuximab, which is a CD38 antibody, very similar to daratumumab, and added the isatuximab in one arm and not the other arm. And I think the reason why this study was important was a few reasons. One, it is the first large phase three study that we've seen adding a fourth drug, or this quadruplet, to VRD. Number two, their primary endpoint wasn't just response rate, but was actually MRD negativity rate, or minimal residual disease negativity, where we look for the tiniest amount of disease left. So people have to have a very, very deep response to achieve that MRD negativity. And indeed, the MRD negativity rate was considerably higher in the four drug combination versus the three drug combination. Still early to make final changes and to immediately jump to quadruplets, but I think there is a general sense in the myeloma community that we are moving from triplets to quadruplets. The other study was the Griffin study. It was a randomized study, but phase two, that was much further along that we were anticipating, where in this case, daratumumab was added to VRD before the transplant for a little bit of consolidation after the transplant, and also actually in maintenance. And in that study, again, it looked like adding the daratumumab at every step of the way deepened someone's response compared to just getting VRD. And historically, we've known in myeloma that when response is deepened, it tends to last longer. Both studies are still too early to really comment on progression-free survival or how long someone stayed in remission. But typically, as we said, that depth of response correlates to the duration of response. And so it's very encouraging. And I'm just Joe. I'm not a prophet, Stephanie, but if I were to predict the future, I'm pretty sure we're going to be going towards quadruplets in myeloma, and lots of options. It's not just going to be one exact four drug combination. I think we're going to be looking at different ones with isatuximab and daratumumab.
Like, how much more does each study need to really have, to get that faith that, okay, this really is as promising as we're finding it now? Like, how much longer will people have to hold on?
Yeah, it's a great question, and nobody exactly knows the answer. But we keep building this case. I mean, the case is becoming more evident, and it's also important that more than one study be done, because that helps us. It gives us greater benefit for the proposed quadruplet. I think in a year from now we're going to have much more mature data, and there may be an opportunity not long thereafter, actually, for this to influence the FDA. We've had already, in fact, in the US, we actually have a quadruplet approved, daratumumab VTD, or Velcade thalidomide dex. We just tend not to use thalidomide here in the US for lots of reasons. So replacing that with VRD, as I say, will likely happen over this next year. And I think it will be something moving forward. It speaks to a philosophy also, Stephanie, that I think is worth mentioning, which is that we are recognizing that what we do earlier on in someone's disease course has a long-term impact. I've sometimes joked and said, saving the best for last is great for a Hallmark movie, but not really for myeloma. That we're learning that what we do in that first line or the first two lines of therapy has a long-term implication. And so we want to be careful always if we add any more toxicity, right? Because someone's going to listen to this and say, well, if 4 is good, why don't we go to 5? If 5 is good, why don't we go to 6? We have to really be careful the impact it has on a patient's quality of life as well. But one of the benefits of these fourth drugs that we're adding is they tend not to come with a lot of risks. Every drug comes with some risk, of course. And I think we're finding that sweet spot with the 4. I think one of the unanswered questions is how long do you continue that combination, and do we need that fourth drug in maintenance and so on? And that's what we're trying to sort out.
Right, because a lot of this is being used before the transplant and then not being tested as maintenance therapy.
Some of them will include us, typically now we use lenalidomide maintenance, but many of them are now testing, can we add a second drug to maintenance? And I think that's an overall theme that we have been seeing over the last few years, that again, going back to my notion of intensely treating the disease earlier. And of course, we balance that with benefit with, the side effects of patients may experience. It's one thing to say, okay, we've got a few months of all these drugs, but if I tell a patient, well, you're going to be on this heavy duty maintenance therapy for the long term, it's more difficult. And so my hope, again, not trying to be a prophet, but if I could predict the future, I think we're going to develop stopping rules for myeloma. I think we're going to be able to understand better. And some studies presented at ASH this year, we're looking at, when can you de-escalate therapy when someone reaches that MRD negativity or undetectable disease level. And those are the kinds of questions that we hope with time. Because if I'm a patient or their care partner or caregiver listening to this today, I want to hear from Dr. Joe, when can I stop treatment? Don't just keep giving me more and more. And so I really do. That is the goal. The goal is not to treat everybody forever. The goal is to treat in a strategic way that can get people down to as little treatment as possible to keep their disease in check.
And in order to do that, we'll just need more of these clinical trials, more of this research, right? That specifically tests for one thing.
Correct. And that's what's wonderful about I've been doing myeloma for over 20 years. I have never seen a more exciting year than the year that we're in right now. The number of trials that are being done to answer these methodical questions are occurring and are heavily influencing the field. Despite what's happened with the pandemic and all the challenges, it's been very encouraging to know that we're working very hard to answer these questions for patients.
I love that. And I want to ask one quick question. I'd seen in this study with isatuximab anyway, that the median age was about 59 and a half years old. So as we know, the median diagnosis for myeloma tends to be more like 69, 70, right? So we haven't been testing that population for reasons, of course. But for that population, I guess, we don't know that it translates yet, right?
Right. So studies are being done looking at this same combination in patients who are typically older and maybe not going to a stem cell transplant. Last year, or even just this past spring at our ASCO and EHA meeting, one of the most important studies was the long-term follow-up of the MAIA study, where we gave 3 drugs, daratumumab, lenalidomide, and dexamethasone, to patients who were not planning to go to transplant. And their average time in remission was about 5 years. The average age on that study, Stephanie, was 73. So it's clear now that when we thought for a while, can we really do triplets in more frail patients? Well, now we know we can. So now we have to ask the question, will quadruplets work? And maybe we modify the drugs a little bit and give them a little less intensely. But really, we've seen huge advances in both sets of populations and really across the board in myeloma.
At least with this GMMG HD7 trial, it looked like they were comparable in terms of the triplet versus the quadruplet. In other words, even adding the isatuximab didn't significantly increase these side effects for patients. Is that right?
That's been one of the benefits of these monoclonal antibodies that, as I mentioned, every drug comes with some risk, and it does slightly increase the risk of infection. And then there can be what we call infusional reactions when people first receive it. But you're very right. Compared to many of the other strategies before, when we've added more drugs, the adverse events or side effects have been appreciably less with this group. And that's so important because safety is paramount, especially when we're starting first line therapy, where we want to protect patients. We always want to protect patients and be as safe as possible with them. But especially in this largest group of people that are being treated, we want to be very careful before we roll out quadruplets that we understand the safety profile of this combination.
And for Dr. Mikhael's entire conversation, head to thepatientstory.com, where you'll find human answers to your cancer questions.